Okay.
Can you see the screen now?
Yes.
Okay. So we present the case of a 60-year-old woman, which was in very good general health with no relevant past medical history. But she consulted to her family doctor for recurrent abdominal pain, biliary colic type. And that's why she had an ultrasound of the abdomen, who found adenomyomatosis of the gallbladder. And due to the thickening of the gallbladder wall, the family doctor asked for a CT scan that we can see here. So we had an arterial phase. And then a venous phase. I guess everybody saw the nodule in the sixth segment.
Mm-hmm.
So here we are, our findings. We found this liver mass in the sixth segment showed an hyperenhancement in the arterial phase and a sort of washout in the venous phase. And we confirmed the presence of adenomyomatosis of the gallbladder. And we also saw a slight dilatation of the main pancreatic duct, probably an IPNM. What would be your next step in this situation? How do you think it would be correct to go on?
Alexandra, since we are all hyper experts here, and,
Okay.
and the people, it was clear that the good answer would have been an MRI. But the patient said, no, I don't want an MRI. I prefer you to take this mass out. And then
she had a very potent claustrophobia, so it was impossible to have an MRI. And we discussed with the patient to operate and do a resection of the liver mass, thinking about possibly an adenoma or a degenerated adenoma. At the end, this was a quite difficult person. She preferred to wait, and as she was still symptomatic from the gallbladder, we decided to just a cholecystectomy. But before, with a endoscopic workup with the NDOS for the dilatation of the main pancreatic duct, we didn't show any particularity, so they didn't see any mucus from the papilla and any nodule or suspect sign for IPNM, and the gastroscopy and colonoscopy were normal.
So
We performed.
I have many questions.
Mm-hmm.
May I start?
Yes.
yes.
Okay. First question: do you have the tumor marker?
Exactly.
All the tumor markers were negative.
Okay.
A complete panel was performed with alpha fetoprotein, CA99, and chromogranin, and there were chromogranin was slightly increased, but all the others were negative.
Now I have a question. I don't have the answer. When you say the Wirsung is 6 millimeter, which is large, for me, thinking about the common bile duct, when we see a common bile duct large, it's different from dilated. For you see, dilated Wirsung. Dilated means pathology. Large, it's only an image. I know for the common bile duct that when you see a common bile duct 6 millimeter, it is large, but no pathologic signification. It could be an obstruction, but not surely. And it is said that after cholecystectomy, there is often an enlargement of the bile duct. So my question is for the Wirsung. I don't know. When you have a 6 millimeter Wirsung, it is surely a dilatation or only a large? You answer after. My third question is this. In my experience, when we have a nodule in the liver, we don't know exactly what is the nature. We used to do what is called a biopsy, but a protected biopsy. We describe the technique. We publish about the risk of this technique. You know what is the double biopsy, the double needle biopsy. That means to put a large needle at the contact of the tumor, but not entering the tumor.
Coaxial.
Well,
Yeah.
coaxial, double, or protected. There are many
Yes.
names. I think that we were the first to publish. I am not sure, but I think we are the first. And then we do the puncture with the Shiba needle inside the trocar to go inside the tumor. And when we withdraw the biopsy, the needle biopsy, there is no contact at all of the extremity of the needle, could be contaminated by tumoral cell with nor the liver, nor the wall, nor the skin. It is totally protected. And we use a lot to do this technique. And apparently, I think this use disappear. For in this case, for me, it is really an excellent indication of this technique.
Yeah. Can I answer, Alessandra? You want to answer?
But I just wanted to say that for the biopsy, this is absolutely right. Our radiologists use this coaxial technique to do biopsy. I think is not abandoned. Actually, we use it at least in our institution. And the biopsy was proposed to the patient, but actually she was really anxious about the mass. That's why at the beginning she wanted just to take it out completely. And it was a very long discussion with the patient. And for the Wirsung measurements, so the maximum height that was measured by the radiologist was 7 millimeters, which is not normal, and was described like a Wirsung ectasia, if I understood well your discussion. They didn't see any other sign of suspicion of degeneration. It was just the size of the duct.
What you said, sorry to continue, what you said is the patient refused the biopsy and preferred to have a removal of the tumor. This is what you said?
Yes, at the beginning.
It is amazing that the patient put the indication.
Yes, and we negotiated that with the patient. Patient has been dealing with cancer patients all her life. She's a psych-oncologist. And
but it happened to me. And then I said to the patient, you are doing my work.
Yes, but real life being what it is, you have to deal. And I didn't like this tumor, in fact, as the aspect of the CT scan. And laparoscopic segment 6 resection is something that Alessandra masters absolutely well. I told her I'm uneasy for that because it could be a benign mass, but it didn't have the typical features of a benign mass. And I agreed that we could take it out. We discussed the biopsy, the coaxial one that we do in our department. No, she didn't want the biopsy. Yes, René?
Okay.
Yes, if I can do a comment, it's indeed a difficult patient because she refused MRI. She refused, I would say, a biopsy. I think we should be convincing in saying that this is a mass which may be benign or tumoral. It could be adenoma. It could be adenoma with transformation of HCC. It could be focal nodular hyperplasia. And I think the conviction could come from the fact that if it is a focal nodular hyperplasia, it is not the typical aspect, but I don't know. At that time, she don't need any operation because it is very unlikely that the pain presented by this patient could be related to this tumor, which
absolutely.
Discovery it's totally fortuitous. So I would say that indeed, she preferred to remove. All the patient have such type of statement, but when we explain that it could go to an operation or not, and the operation could be different if it's malignant or benign, at that time, I think the patient accepts what we are saying to them.
Exactly. So we could negotiate with the patient, because by the time he said, "Madam, we can do a useless operation for you, which is only dangerous and not useful at all." And she said, "I'll think it over," and discussed with an anesthetist who scared her a little bit. And then she said, "No, I don't want the operation, in fact, anymore. I just want the cholecystectomy, but not the operation."
Pietro, just one thing. I think when you look at this, you have three problems. You have the adenomyomatosis, you have the dilation of the bile duct and the pancreatic duct, or at least the slight enlargements. And then you have the nodule. For the second problem, this dilation, did the ultrasound saw any kind of anomaly of the pancreatico-biliary junction? Because we saw that there was no problem in the ampulla.
No.
And the second thing, when we think about doing, for example, a laparoscopy in a lesion like this instead of a biopsy, I think this may be a little tricky because it looks very simple to resect laparoscopically, but this is not the same as a lesion that is totally in segment 6, and it is very easy to take. This kind of lesions is more 6, 7, and by lap, it's not so easy as it seems. This is my experience. It's not very
absolutely,
but it's not very easy also.
Absolutely. But then we could negotiate with the patient something else. She wanted the cholecystectomy because she was symptomatic of gallstone migration, and that was a clear indication. And said, well, during the operation, we do a biopsy passing through the part of the liver that we would take out if the tumor needs to be taken out. And this we did.
That's what we did. We performed the cholecystectomy with cholangiography.
It doesn't really look like an HNF, huh? This is intraoperative ultrasound.
Is this one? Sorry. And the pathology from the cholecystectomy and from the biopsy showed a chronic cholecystitis, and actually, pardon.
Yeah.
Lost it. So it showed a suspicion of biliary duct adenocarcinoma at the beginning, as it seems very strange, this diagnostic to us. We discussed with the pathologist to reassess the biopsy, and we can see here all the positive staining for markers, and at the end it was a very strong positive staining from chromogranin, synaptophysin, and key 67 of 20%. So the final pathology from the biopsy that we performed was a neuroendocrine tumor, G3. That
and
was
then,
surprising.
And the primary was not, so we should not do
and this is what we did, René. Alessandra, you continue.
Yes.
So we searched for a primary. We already know that the gastroenteroscopy were absolutely negative. So as the key 67 was very high, we performed first FDG PET-CT, which was completely negative. So we didn't find any uptake where the liver mass was, or nor in elsewhere in the body.
Did you perform a dot and knock also?
Exactly. So we performed also gallium PET-CT, which show a high uptake in the liver mass with any other uptake localization. So we thought about a possibly primary hepatic net or a metastasis from an unknown primary. And we then performed the resection. The patient did very well, and we can see this is the final histopathology on the complete nodule. So the Ki67 were 25%, was a 3.5 centimeters tumor, and the rest of the liver did not show any fibrosis, and the resection was complete. And we discussed again in the multidisciplinary meeting with a proposition for a close follow-up with another CT.
Sorry to interrupt you. Just during the operation, did you took the opportunity to look as much as you could the small bowel, because this would be the first site in principle of a possible primary?
Yes, we had a look at the exploratory laparoscopy, and we didn't find any irregularity in the small bowel or other.
Yeah, but you did not perform palpation.
We did not perform palpation, no. But we relied on the fact that the mass had a very high uptake at the PET CT. So if there was any other suspicion of primary lesion elsewhere, normally we should have seen it on the PET CT.
Unless it is very small. Because this
Have you discussed any possibility of adjuvant treatment? Because clearly G3, as you know, are not classically a good indication for surgery. I would have done the same that you have done, huh? But usually it is said that surgery is indicator for G1 and G2 neuroendocrine tumor, not for G3. But in view of the fact that he was totally isolated tumor in the liver, I would have done the same. But possibly because of the aggressiveness, the Ki67 is 25%. Possibly it could exist an indication for doing at least somatostatin, or even, I don't know, if chemotherapy in an adjuvant setting, knowing in addition that we have no primary, could be indicated. Have you discussed this aspect?
We have discussed this with our oncologist, which is quite specialized also on neuroendocrine tumors. And she agreed with the surgical resection because this looked an isolated mass. But we have discussed the option of a systemic treatment.
Mm-hmm.
I have another remark. I remember I read some article on the possibility in some hepatocellular carcinoma to have neuroendocrine cell. That means association of both. Mm-hmm. I don't know if it is possible to have a complete neuroendocrine simulating hepatocellular carcinoma, but I know there is some mixed tumor. Did you know about that?
We have some cases of mixed with a small component of neuroendocrine. I think that's rather frequent.
Exactly, a small component. I think it is not the case. So my question is it possible that this is not a true net tumor, but I say a masked hepatocellular carcinoma? Well, it is strange, it is alone, you know, it is primary. I don't think about primary. This is a question to ask the pathologist.
Mm-hmm.
We can ask for a second reading. In fact, on the first, they did quite a battery of tests, and I don't know whether they did also but we can go back and look for the hepatocellular carcinoma markers. I mean, this is clearly an exceptional case. This is a summary. Probably they did other ones. This is a very exceptional case. In my experience, it's the first primary liver net that I see, and I expect a metastasis, a primary, in fact, of which this is a metastasis, to lit up in the future. And I rather agree with our oncologist who's a particular interest in neuroendocrines to wait, because we have no target, so we don't know what we're doing, and do a 3 monthly CT at the beginning, and then a gallium PET at 1 year. But
yes, what about the dilatation of the Wirsung duct?
she has to bring it along every time she does a CT or a PET CT, so we can follow it automatically every 3 months at the beginning.
I have a same patient with lymph node of the hepatic pedicle, very, very big, small of like pedicular lymphangitis, only neuroendocrine in a patient young, very, very good condition. And I did a lymphadenectomy of celiac and pedicular, and we should be now at more than 2 years without primary. So he have removed, he looked like well, and so on. And apparently the primary is still not discovered as in young patients.
Okay, so we have Manuel here from Dominican Republic.
Good morning to all. So I had a similar case, I just wanted to mention, with a young lady with a unknown primary G2 with a liver metastasis. And in that time, I also went for the wait and see. And at the end, she had a brain metastasis. And she went for a neurosurgical procedure and a liver debulking, and now is pretty much controlled with somatostatin. So I would not delay this all too much. There is shown, even if you do not have a primary located, the resection of the liver tumor does bring a benefit. Avoiding growth, because sometimes these tumors grow to a size where when you want to resect it will not be possible.
In this case, it's already resected. So what we have to do, in fact, is surveillance. I think, in my opinion, it is likely that at some point a small primary is going to appear, because but of course it might be an unusual case of
You will keep us informed.
Yes,
we will.
So we should move to the next case, if you agree. So I ask Pedro to start the presentation.
Please, I have a question, if you can hear me.
Yes.
Yeah, thank you. I'm Dr. Jalal, a student with Professor Daniel Cherki. Thank you.
Hello.
The first question thank you. The first question is, during the diagnostic process, as the patient is claustrophobic, doing MRI under GA isn't an option, as the MRI is superior in the diagnostic process. This is the first question. An option to do MRI under GA. The second question, as we know, the laparoscopic exploration for the small bowel to look for the primary is not superior. Doing a capsule endoscopy isn't an option for looking to the primary, as we know the small bowel is the most common site for the primary neuroendocrine tumors.
Pietro, what do you think?
We end up in Geneva. We did MRIs for children under GA, but in Ticino, we don't do MRIs under GA in general. We do them under hypnosis. It is in fact quite rare that we have a patient like this in whom we can't get an MRI. It's very rare. Generally, you convince them, you get the husband with them or whatever, and so the whole gimmick of having an MRI compatible anesthetic equipment for these occasional patients, we don't have it. I don't know what the experience of the others.
We occasionally do them with the general anesthesia. I think hypnosis is a really interesting option.
About, I would say, eyeballing it, about 80% who are claustrophobic, we can get away with hypnosis. And we will send them to Portugal for MRI under GA.
Actually, it happened to ask some MRI under AG to our radiologists, but the remark they have made that it is very hard to match the images with and coordinate with the respiration. So they need the collaboration of the patient.
Yeah.
For
So we move on, because we have, I think, at least 2 more cases, perhaps 3. This is a case where we actually need your opinion. So can you begin, Pedro? We can't hear you.
You are mute. You are mute.
Pedro, you have to activate your microphone.
Okay,
Yeah.
can you hear me now?
Yeah.
Yes.
Yes.
Can you see the
Okay.
presentation?
Can
as
start.
well? Yes, okay. Okay, so good afternoon, everyone. My name is Pedro. I'm from the surgery department. I will present you a case of a female, 22 years old. She was firstly diagnosed at birth with a Todani cyst type 1 and was submitted to an hepaticojejunostomy at 49 days old. She had recurrent episodes of cholangitis until she was 16. She was then started on ursodeoxycholic acid and showed great clinical improvement after that medication. She got to us at age of 20, and since the age of 18, she was again having cholangitis. We discussed her on our multidisciplinary team and decided to do a rehepaticojejunostomy. She had a normal liver function when she got to us, and so she was submitted to an hepaticojejunostomy again. Intraoperatively, we found multiple intrahepatic lithiasis. We show you here the pictures of the surgery. Here on the local of the previous anastomosis, we can see the stones, and also here. We could not remove all of the stones. Unfortunately, it was not possible. But after the surgery, she improved quite well and was discharged with normal bilirubin. She was well for 2 years after that, until last May, when she again had another complication. So now she
just interrupt you, Pedro, to say that at the point the surgeon who operated the patient tried to remove all the stones, but they got under the impression that probably there would perhaps be small stones in the subsegmental ducts that would be impossible to reach. So he was not very convinced that this was a complete cleaning of the bile duct at that time.
So she was admitted again for an hepatic abscess this time. Her blood work was abnormal with elevation of the inflammatory markers, and the CT that she did showed dilation of the intrahepatic ducts in relation to hepatolithiasis and had an hepatic abscess. She was also on cholangitis. Here are the images that we have. I'm going to run them one more time.
Can you hope? Yeah.
No injection?
No injection on this.
No injection
on this.
in this CT scan. We have an MRI.
Yes.
Afterwards.
This was her imaging, and she completed 1 week of piperacillin tazobactam with no improvement. So she had persistent fever, and we did an MRI that showed the cholangitis that we already knew and the hepatic abscess. We have it. We have the images here. I can run it one more time. And I have this one as well to show.
Okay, so at this point we couldn't we couldn't identify an actual stenosis of the bilioenteric anastomosis.
Yeah, however, it seems as if there is a big stone casting the whole bile duct.
Yes.
Above the anastomosis, which is either corresponds to a stenosis or creates a stenosis.
And you can see there are several, and this can be seen also in the CT scan. But there is at least one big one that could be causing this obstruction.
So this abscess was drained, and she improved quite well after that, and she was discharged asymptomatic. And so this is we now ask you, what would you do at this time? Do you have any suggestions?
Monsieur Bismuth, j'ai muté votre micro.
Sorry?
I was telling Monsieur
Voilà, ça y est. Vous l'avez maintenant?
Oui.
Vous entendez maintenant?
Yes, yes.
Oui, yes.
What I said is that indeed we have a lot of experience in Petrus about intrahepatic lithiasis. The main reason is that we receive, I don't know, it was at my time, we receive a lot of patients with biliary stricture, neglected biliary stricture. And the biliary intrahepatic lithiasis was due to the stenosis, the long neglected stenosis of the anastomosis, which was performed initially. And the treatment we used to do is, of course, to do surgery in order to improve the anastomosis, but it was not enough. Even when we spent hours by cleaning, by lavage of the bile duct, by extraction by the clamp of the bile duct, we were never sure to have drained totally the bile duct, intrahepatic bile duct. And for me, what was necessary is to let the possibility to come back inside the intrahepatic biliary. And the way was to bring the loop of the biliary, the jejunal loop, near the skin, to fix the skin, and to do external maneuver by finding the loop by ultrasound and by punctioning, putting a tube in order to clean and to repeat the cleaning periodically in order to achieve, we hope, a total cleaning. That means the treatment of this kind of intrahepatic biliary intrahepatic stone is not only to have a large drainage by redoing the anastomosis, but to let the possibility to repeat cleaning and desobstruction of the hepatic. It is the case with new patient. You treat the patient very well. It's good now. She has no more drain, but you are not sure that there is some stone remaining. Stone means evolution where an obstruction. And when there is obstruction, there is abscess. So treatment is to try to achieve a total cleaning of the intrahepatic biliary tree. This is my my solution.
Okay. So any other comments? Perhaps we should move.
No, I would agree on, of course, what Monsieur Bismuth was saying. I think another comment is that it seems to me that there is a relative hypertrophy of the right liver, possibly showing that the disease is mainly on the right part of the liver, but not only on the right part. This is the first point. For trying to clean, of course, an approach by the small bowel loop could be more interesting because it could be combined also with lithotripsy. And so by this way, it could be when we have the tract, it's possible to renew all the maneuvers in a way to disobstruct and try to solve at least, I would say, the majority of the liver, and especially the left part, which seems to be hypertrophied. But for me, I would agree that the problem is much more the intrahepatic lithiasis rather than a technical problem. To redo a third time the anastomosis, in my view, will not solve the problem. So whether we use the loop to try by the reverse approach to try to disobstruct the biliary tract, or if we don't succeed, to do it by transcutaneous, transhepatic approach. But by this way, we will not treat all the biliary tract. We will just treat only a part, a segmental part of the liver, and this is the inconvenience to do it by a transhepatic approach.
But René, it is easier to do by the loop. In addition, it is elegant, for there is not at all opening of the abdomen. You puncture the loop, and then you may repeat the operation regularly. I think it is important to do even preventively. That means every 6 months to ask the patient to come back, you do a puncture, and then you do a cleaning, lavage, lithotripsy if you find stone, and radiology control. This is very important. You put a tube in the common bile duct, I may say in the upper part, and you do a total cholangiography, and you see exactly what it is. If there is stone, you may direct the lavage. It's really very important. It's not simple. It's a long step. It could be 1 hour in the operative theater by doing that, but why not?
It is the best, but it needs expertise, of course.
Yes. One of the problems is that we didn't have the loop prepared to do this, and the radiologists are also quite afraid of accessing the loop. But I think perhaps Pedro will continue.
Yes, so we tried precisely to clean the rest of the bile ducts. So we discussed her on our multidisciplinary team, and the plan was to perform a percutaneous transhepatic cholangiography and extraction of the lithiasis and cholangioscopy. And what the cholangiography saw was that there was multiple hepatolithiasis that we already knew that existed, and there was an unsurpassable stenosis that did not allow us to do a spyglass and remove the rest of the stones. So the only thing that was possible to do was to leave an external-internal biliary drainage, which we did. And I have some images of the procedure to show you. Once again.
So our idea was to use the external routes to try to destroy the big calculus and eventually with the cholangioscope, but it was not possible at all. The only thing we could do is a better drainage, but of course this was not very effective, and we ended up closing the traject and removing the drain 1 week after this was solved.
Exactly. So now we ask the audience, what would you do? Any ideas?
what could be also in a way to improve the efficacy of this obstruction of the left bile duct, what we can also do is a sort of technique of rendezvous, because Henri Bismuth was proposing to go through the loop, but now that we have a drain, possibly by ultrasound, it could be much easier to repair, I would say, the loop, and so to puncture transcutaneously this, and so to have a sort of Prader-Willi drainage with, I would say, one part which is transhepatic and one part who exit from the loop, you know, and by such a way, it's very easy, even without anesthesia, to change the drainage very, very frequently if needed.
The problem, René, is that after the episode of cholangitis is finished, this access was removed. So you don't have a drain now. You just have the same situation.
You can put it back very easily, Hugo.
Sorry?
Hugo, you can put it back very easily. If
Yes,
your radiologist is not brave to puncture, then it's you can puncture the liver or pacify, as René said, and push them with more courage to puncture an opacified loop, which it will not be blind, and then do it from below. If you do it from below, it's so much easier. From above, it's hell.
Yes, it's
what I know, Hugo, it's really a work of patience, a long time for, you know, when the patient come to do this external maneuver by direct approach from the loop, or as say René, by the double approach, transcutaneous and by the loop, but then doing a cholangiography, looking exactly what could be the place of the lithiasis, then go there to do a lavage, to do an endoscopy. It is very long. I am not sure that the radiologist alone may have the patient to do that. For us, it was in the operating theater with mainly the surgeon, but it could be 2 or 3 hours to do this. But at the end, we must clean the maximum the biliary tree, and then we wait, the patient return, and but it must come systematically every 6 months.
I think it's probably the best way, and perhaps we can use the cholangioscope at the same time.
You can use an endoscope. You can use a fully big, chunky endoscope to go in.
Hugo, you must have in your team somebody specialized for that. It is
very patient.
Patient with a lot of instruments, small, large, doing cholangiography, turning the patient cholangiography in order to see the posterior part of the liver. Really, I think that the stone are autochthonous stone. That means they are formed. When you have a stone blocking a branch, there are new stone above. And this is terrible. We have to avoid this. This is why we have to remove all the stone that we see. And then lavage is important to remove the small stone.
Okay, I think I'll let Pedro finish. He has just last information because she has a new admission. And I think this is what we're going to do, but please, Pedro.
Yes, just to mention that once again, she was admitted in the end of last year for a new cholangitis episode, this time with no abscess. We have the most recent imaging of her to show you. So this is the most recent CT scan that we have.
She's filled with content inside the intrahepatic bile ducts.
So the question that we brought you was that if there is any other solutions, a non-surgical solution, or if we have advanced for an hepatic resection, transplant, or as you were suggesting,
I think this is a very good suggestion, and I think this next step to puncture the jejunal loop to try to clean better the bile duct is what we are going to do next. Okay, I think in the interest of time we should move on.
Ugo, just a second. And if they don't want, I think you operate on her and you put yourself the loop in an accessible way with a catheter, so that they.
We can actually do this in the operative room, even with the radiologist, and we can do it conjointly, and it's going to be.
Hugo, what is the length of the cul-de-sac of the loop?
60 centimeters.
No, the cul-de-sac.
The blind
The cul-de-sac is not. It's well, I'm not sure in these patients, but it's usually very short.
Yes, usually we do very short in order to avoid stasis in the. But unfortunately, in this case, we need to do a long.
Yes.
When you do a general loop for
what is sure.
We do a long, and we suture the extremity of the long cul-de-sac to the skin.
Yes.
Not to the skin, to the wall.
To the wall, yes.
You know, in order to have a direct puncture under the skin.
Hugo, what is sure for me is that in these young patients, we will come one day to transplantation. But in our experience, to approach, I would say, and treat symptomatically the intrahepatic lithiasis by the loop may gain sometimes several years, if not sometime 5-10 years, before going finally to transplantation. And so this, in my view, is I would say, the challenge. Of course, in the present situation, we say, why not transplantation? But if we may wait for many years before, it's a sort of advantage for her because she is very young. And by the loop, in my view, it could be the best way to try to obtain a good compromise.
I think this is a very good suggestion.
You know, indeed, I tell you something to all of us. We don't have a lot of experience of intrahepatic lithiasis, indeed. At the difference of the surgeon in Asia, there are a lot of, much more intrahepatic lithiasis that we have. And we don't have a lot of experience, and we have to learn. I speak about Paul Bruce for, due to the stricture of the bile duct was a benign stricture, but we don't observe intrahepatic lithiasis in cancer, too short evolution. But in biliary stenosis, we have, when there's a recurrence of the stricture of the biliary anastomosis after biliary repair, it's long time, and sometimes we discover the symptom recur due to the lithiasis. And then we discover intrahepatic lithiasis. This is why I say in Paul Bruce, I remember this. We have a lot of patients with intrahepatic lithiasis. I wrote a lot of paper on this about the way of dealing with that. But what I know, and I said, we need to do the most complete lavage and cleaning of the intrahepatic bile duct each time, and letting the possibility to have access by the percutaneous.
Oh, very well. So we move. Pedro, thank you very much. Yep. I think we would continue with the case of Beatriz. This is also a case that we need your assistance and your opinion. So Pedro, if you can go out of and share the screen.
So good morning, everyone.
It's Beatriz.
Quite similar. So I will begin presenting this case, which is of a patient that's currently admitted in our.
I'm sorry, Beatriz, just a comment. So Beatriz, she's a resident from our department, and this case is about a young patient that we treated for a long time and that we all know very, very well. It's like it's a special every patient is special, but this is one of those patients that everybody knows in the department.
Yes. So without further ado, so this case begins in 2010. Patient at the time was 19 years old and presented to us with a right upper quadrant pain and a history of blunt abdominal trauma 3 months prior. He did an ultrasound, which showed a mass in segment 5 with about 8 centimeters. At the time, it was thought that maybe it could be a hematoma. His blood tests were all normal tumor markers as well. But a CT scan was performed, which showed the mass.
But
And,
it shows slower.
yes, it was slower. Yes. So, wait, sorry. Okay. This mass, which could be, well, as you know, a primary liver lesion, or maybe malignant lesion, or maybe a focal nodular hyperplasia. So we did an MRI to see it a little bit better. And the MRI had some characteristics of
I have an hypothesis.
Okay, yes, please.
Please, Pietro.
I think this is a pseudo central scar. In fact, it is a fibrolamellar hepatocellular carcinoma.
Yes, that's absolutely right. Yes. So the patient was discussed in our meeting, and in May we performed a subsegmentectomy of segment 2 because there was also a suspect nodule in that segment, and the segmentectomy of segments 5 and 6. So segment 2 was just normal liver parenchyma, but in segments 5 and 6, which is the mass that we're talking about, the diagnosis was the fibrolamellar carcinoma, which was classified as a P3A and N0, M0, and with an R0 resection. The tumor had no capsule, but on the other hand, it had no vascular or perineural invasion. So we discussed it again, and we decided not to do any adjuvant therapy. And then patient began follow-up. And about 1.5 years after the surgery in September, we noticed that there were 2 enlarged lymph nodes in the anterior costophrenic angle, about 3 and 2 centimeters each, with an SUV of 2.7. And we discussed it, and since there was no other disease, we excised the nodules through a mini anterior thoracotomy. So in total, 4 nodules were excised, and 2 of them were lymph nodes with carcinoma disease. The patient underwent the radiotherapy in November 2011, and then 1 year of sorafenib. From 2012 until 2014, he was disease-free, but in 2015 again, there was evidence of a lesion near the resection margin in segment 5 that was operated on. So we did a segmentectomy 4B5 with a Healer lymphadenectomy in July 2015. And
sorry, just to interrupt you a bit. So what we did at this point was a resection. So it was not really a 4B5 segmentectomy, but it was a resection of the sites of the recurrence. And at this point, we decided to do adjuvant sorafenib, although it was not completely accepted as an adjuvancy in this setting.
Yes. So after the sorafenib in 2015, about June, there was a suspected local recurrence in the PET-CT scan, and that was treated with radiotherapy with success. So the further exams didn't show any evidence of disease in the liver margin. About at this time, the patient began complaining of GE reflux symptoms, and an endoscopy was performed, which showed this ulcer that in this image on the left here, which is an ulcer in the duodenum, and it was quite big, about 2 centimeters, and it was presumed to be caused by the radiotherapy. Sometime after that, in June 2016, the patient presented in the emergency department with a duodenal perforation from this ulcer with a pneumoperitoneum, but relatively a small quantity of free fluid. So we decided to treat it conservatively, and patient actually did very well with parenteral nutrition and antibiotics, and he recovered fully from that. So in 2018, there was another lesion found, though this time at the aortocaval lymph node area, and we excised that as well. And there was no evidence of lesions elsewhere. And until 2022, he was clinically well and with no other evidence of disease, until we found this retropancreatic lymph node. So we decided to perform an endoscopic ultrasound, and we did a fine needle biopsy, which was compatible with the metastasis of febrile lamellar carcinoma. Of note, I should say that when they did the fine needle biopsy, there appeared to be the puncture site didn't fully heal, so they thought it would be better to close it with clips. But then he did a CT scan which showed no leakage or fistula. So regarding this nodule, what we did was we decided to excise it through a laparotomy in this last December, which went very well. The patient was discharged at day 4, and the pathology, the final report, confirmed that it was a metastasis of his carcinoma.
So to again interrupting Beatriz, this was in December, and this patient, which is now almost 30, I think.
31.
31. This is a 13 years history of disease, and this patient is a patient that usually spends his time. He likes to do radical sports. All the time at that hospital, he was always asking me when he could leave because he wanted to go skiing. So he's a very active person, and he's in a very good physical shape. And this is something that he sees as small adverse events that preclude him from doing his everyday life that is like that. So it's and finally, Beatriz can continue, please.
Yes. So this month, on the 18th, he presented in the emergency department with a history of 3 days of fever, nausea, and vomiting. His blood tests show the elevated inflammation markers, as well as slightly elevated AST and ALT, and a GGT of almost 3,000. So this is his CT scan 10 days ago. It shows some fluid and air in the right lobe, which is, and also some air in the bile ducts. This is just another view.
Can you show again slower, Beatriz, please?
Yes, the axial.
Yes.
Sorry.
Okay.
It is an abscess?
It's an abscess?
Yes. Okay, so what would you do now?
This was reported as having air in the bile duct, that is something that I am not sure. Any thoughts?
There is an abscess in the liver.
Yes.
Why not to start draining the abscess by needle punction, putting a small vein?
But what is the cause of this abscess? Are we sure that all the vessels are totally patent? Because this patient has no history of biliary stenosis or something like this. So what is the cause of the abscess? Is there any other infection, abdominal infection or perforation? I don't know.
No, but this is, so this is a patient that had radiotherapy in this location,
Yes.
had a perforation, and that had a recent perforation of D3 by echoendoscopy, and then had a surgery where the duodenum was slightly moved to get access to that retroperitoneal node that was actually metastasis from HCC.
The way to answer your question is an abscess, you drain the abscess, you let a small tube. Then, or there is only pus coming, or after the infection removed, you have bile coming. At that time, the abscess is due to cholangitis. The only way to do that, and then you do X-ray and you find the bile duct. But to part between a true abscess or cholangitis abscess is the bile coming from the tube.
So can you move on, Beatrice?
Yes.
Ugo, can I just, looking at the new anatomy, I think you are in fact in a very difficult situation, because I think the posterior duct that goes above the portal bifurcation, the anterior sector has gone here. And I think that is where the duct of segment 6 and 7 probably goes above the portal vein, and it's very fragilized. It's rendered very fragile in the post-surgical area and in the radiotherapy. So I think, I'm afraid, this is a start of a problem.
So you think this is an anteportal variation of the bile duct with the posterior?
I think, from what I understand of the anatomy, I would need more time, but the posterior duct is going where your clips are.
Yes.
And
yes,
this is a region that has been rendered more fragile by the surgery and the radiotherapy. And I think if you pacify the access, as Mr. Bismuth is saying, you have that posterior duct channel. This is the portal vein. This is the duct that does like that.
The Hartshaw's crook, yes. That is perhaps exposed with the surgery, yes. And this is important because I think I also agree that we might be facing a problem like that. Beatrice, can you move on just to show a little more?
Is there also a thickening of the small bowel there in this at the end, one of the last images of the CT scan? Is there not a thickening of the small bowel?
Perhaps a little thickening. And I agree that we probably have some kind of fistula between the diseased duodenum and the bile duct at this level. That's what I am afraid of.
There in the left part, it's like, looks like an invagination.
Yes, but that's something you see sometimes on CT scans. I wouldn't care too much about that.
Can you go?
But Alessandra is always right in the department, so beware.
Maybe looking at the whole CT scan, I don't know if the radiologist mentioned other things.
We have one more to show you.
Yeah, they didn't mention any changes in the small bowel. But
okay, proceed, Beatrice, please.
Okay, so we thought that, well, we have the abscess, and we thought that maybe there was some kind of fistula. The site that we thought was most likely was the duodenum because of his previous history. So we started him on parenteral nutrition exclusively. broad spectrum antibiotics, and we did a percutaneous drainage of the abscess. And patient is improving. His blood tests are getting better. Clinically, he is always very well, as Professor Hugo has already told you. But his CT scan after the drainage still shows the abscess in roughly the same size, and there is still some edema in the parenchyma, and
I can tell you what
free fluid.
The drainage was essentially pus at first, and now it has a little bit of bile, but in a very small quantity. And is in fact improving. So this is our situation now.
As Monsieur Bismuth said, you should opacify this drain, because he's dependent on that drain now.
So you think perhaps the best would be to opacify the drain, to do a cholangiography through the drain.
Yes.
What about, for example, an MRI with excretion phase?
Yeah, I don't think you will have enough anatomical detail, but please do.
And I think for the moment we have to wait and see if he improves conservatively without not doing anything else. But I think this might be duodenal fistula to the bile duct at some point.
What is coming from the drain?
A small amount of bile, but very small. I think
that means there is communication.
Yes.
You may do cholangiography.
Yes. Okay, so any other thoughts? I think we have to do that. Alessandra wanted to speak.
I had a question, another question about the lymphadenectomy on the first resection you did. You showed a T3 and 0, but in 2010, but the hilar lymphadenectomy was performed in 2015, right?
No, in 2010 we did a lymphadenectomy, stations 12 lymphadenectomy, assuming it was an HCC non-cirrhotic liver.
Okay.
And these are lymph nodes of probably station 13A or 16. These are nodes, retropancreatic nodes.
Okay.
Hugo, on a carcinological point of view, I would say that this patient, unfortunately, will recur probably in view of his long history. And I suppose that you have been able to do a complete biological molecular approach, because as you know, now we are a very moving field in terms of new molecule, new drugs with immunotherapy, nivolumab, pembro, lenvatinib, and so on. And if we could have the chance to be responder to one of these therapy, according to the gene mutation of his molecular profile, possibly we will be able to prolong, because it's very unlikely that you will be able to do an operation every 2 years, you know.
Yes.
So I assume that you have done it.
I can tell you that this was sent for Foundation 1 for analysis.
Okay.
Until now, we have no results, but I think this takes some time.
Very interesting case.
It's a good evolution 13 years after resection of fibrolamellar carcinoma. It's good, but it's already extrahepatic, unfortunately.
Okay, so I think
Tim is saying something.
Tim,
I was just highlighting, we just had a review come out in JACS last week that highlights the systemic immunotherapy approaches for these patients that Renee was just highlighting. So I put the link in there. this, and it
Yes.
highlights all the different clinical trials that are currently open with different immunotherapies for lamellar.
Yeah. Can you send the PDF, Tim, please?
Yes, I will.
Yes.
Thank you.
Thanks, Tim.
So at
Thank
this
you
point,
very much.
we have Atezo with Bev as first line, right? In these HCC recurring HCC patients, we are already, and in this situation we already have a reasonable response rate. I think it's above 30%. Well, let's see. Okay, so we start with cholangiography. We'll do an MRI with the Primovists, and we will keep you updated. And we hope that he passes this complication without any further any further problems. Okay, so I think Alessandra had a fourth case.
Actually, the other case is a pancreatic case that we have already discussed here with the Compagnons. And this is a Portuguese patient, so that's why we wanted to show, especially to you, because the patient is coming back to Lisbon in some months and probably take contact with your institution.
It's an exchange of patient between.
Exactly. But
Exactly.
we've done that. That's an
Fantastic.
advantage. Yeah.
Okay, so can you see the screen?
Yes.
Okay, so he's 69. He has a metabolic syndrome, so he's diabetic, obesity, hypertension, hypercholesterolemi, and due to some renal colic, he had a native CT scan which showed a lesion in the head of pancreas.
You can put it full screen, Alessandra. We see the presentation. Yeah.
So he had this CT scan looking for renal stones, and it was found to have a mass in the pancreatic head. He had the MRI, and this is the T2 phases. So this honeycomb aspect make us think about serous cystoadenoma, but he had quite a big retrodilatation of the pancreatic main duct. So we see here the reconstructions. He doesn't have any exocrine insufficiency symptoms at the moment. We have seen the patient recently. He had an NDS. We confirmed the diagnosis. And this is the follow-up of the lesion from 2019 up to now. And what we saw actually is an increasing size of the mass, but what we saw also, and we found quite worrying, is a compression on the vena porta. Which was not evident, it was not present on the first images. So actually, he has an involving mass. We know that it's 100% benign, but is going to compress the portal system. And that's why we discussed it last time for indication to surgery in an asymptomatic patient for now.
Mm-hmm. The tumor markers are normal?
Yes, the CA-189 is negative, and we are quite sure about the diagnostic of of a servocystoadenoma, because also on the ultrasound images he had a characteristic
honeycomb.
Okay.
It's not
And
very
central
typical
calcification.
It's not a very typical evolution of the serous cystadenoma, nevertheless.
No, but we decided already that we wanted to operate on this patient. So we are sending it to you. Not we are sending, he wants to come to you. We try to discourage him and to be operated by us, but he insists on coming to Portugal.
At that time, okay. But what to do else that operation? And I think the operation, we have to discuss the technique of the operation. Objective is to do enucleation. It is possible to do by the CUSA, the CUSA at the contact of the cyst, keeping the cyst not open, may do a real enucleation. It's not difficult. There is a line of passage, and it is possible to do that. I did 1 or 2 times a total enucleation without opening the cyst inside the pancreas. What do you think?
How will you manage the main bile duct, which is very, very big?
But it is compressed, no? It is the compression by the cyst.
Probably.
No? At the time, if you remove the cyst, it's enough.
Yeah. Now, Alessandro, yeah.
These enucleations in these large tumors have a very high rate of fistula. I'm not sure if it's not better to opt for a pancreatic duodenectomy because of this. I'm not sure what's your opinion, but I'm divided.
I think you can do both. You can start with enucleation, see how it goes, and then move on to a pancreatic duodenectomy or to putting a loop of bowel on the crater that's left.
I agree. We may start doing enucleation, and if we succeed, why not? It's enough.
Tim is smiling.
Tim is going for a Whipple.
I would just do the Whipple. It's the operation that we do. I don't. The idea of putting a loop of bowel on a crater, makes me nervous. I mean, I feel like trying to enucleate, it's pretty big, and I do worry about a fistula. I would do a Whipple.
Well, Hugo, you will tell us, huh? Hugo, we asked the patient to lose a little bit of abdominal fat, which is in general very easy when they come to Portugal.
Okay.
A big patient.
Okay, so I think no more cases for today, I think.
No.
Okay.
I think
No.